Uh, Hello, everyone. I'm very pleased to be here to talk about vestibular implants, a subject that our teams have been working on for a while now. So I will try to do a bit of summary of what we have done over the past years and to discuss a little bit with you what we plan to do in the future, because this research is ongoing and we're very excited, but there's still a lot of work to do. So, of course, I'm presenting on behalf of our entire team, Geneva and Maastricht, and you'll see that the work has been amazing so far. So I would like to start by defining what is a vestibular implant. And a vestibular implant is a new neuroprosthesis. And what is a neuroprosthesis? It's a device that's designed to artificially restore some kind of function, in our case, vestibular function, to patients that have a severe loss of this function, in our case, bilateral vestibulopathy. And this device is new, so we have to follow several steps to achieve some kind of clinical application, similar to any other medical device. So what are the basic steps? First, we have to identify a clear unmet clinical need, right? And in our case, I think it has been established that bilateral vestibulopathy is a real unmet need. So why should we develop this device? This is the question that we will need to answer. First, then we have to think about how classic physiology works and try to replicate it some way. And this is how do we make it work? And finally, we need to validate it clinically. So we need to find out if it's really useful or innocent. So this is the way that I'm kind of going to structure my presentation today, trying to go through these questions so that hopefully we're very confident that we can soon achieve some kind of clinical application. So why should we develop the device? It has been established already, so I will not talk about the great impact of bilateral vestibulopathy in quality of life. I think one important thing that has already been discussed, and I will not spend too much time on it either, is that there are very few treatment options for this patient. And the first option is, of course, patient counseling. We should never forget that counseling is essential in this condition. The patient needs to know that we understand his problem, and give him as much hints as we can to make his life easier. So first, of course, talk about ergonomics at home, comfortable shoes, that's important in this population, and maybe walking sticks or canes to support them. So it's very important not to forget this stage while we're talking about new devices and new developments and rehabilitation, but counseling is essential. Then vestibular physiotherapy, we have already discussed it too. It can help to some point, it can help build up new strategies for these patients, but the vestibular system is the fastest sensory system in the body. So there's nothing that can compensate it for it in some situation. So that's something that you need to remember. This is why we often say that patients are not happy. Because you can try to compensate, but dynamic it will stay. And this is why we're developing all these devices to try to help these patients. We have talked about these sensory substitution devices like the balance belt that Herman just talked about, galvanic stimulation, what you just heard before, and now my turn to talk about the third strategy, vestibular implants. So how do we make it work? So we said already that we need to replicate the vestibular physiology as close as we can. So the idea is for the system, we need a system that works in a way similar to the cochlear implant. When we try to artificially replicate auditory function, here we need to replicate vestibular function. And how does it work? So very briefly, here you have the pathway of information of the sensory information that the vestibular system treats. And actually, this pathway is very similar across all sensory modalities. And the same steps are undertaken. First, we have the physical stimulus. Okay, in our case, the vestibular system, it's head motion. In the case of the auditory system, it's sound. In the case of the visual system, it's light. So we need a system that's specialized to detect that physical stimulus. In our case, it is the vestibular system in the inner ear. And this sensory system will transform this physical stimulus into a form that our nervous system understands, which is electricity. That's what it does. And then this electrical signal is sent through the vestibular pathways all the way to the brainstem and the brain, where it can be integrated to generate reflexes. So that's the classical one. And with the vestibular implant, what we will try to do is replace this dysfunctional sensory system by some kind of electronic devices that can do this transduction. So we will need a sensor, a gyroscope in our case, because we're implanting electrodes in the semicircular canals, and they detect angular velocities and angular accelerations. We need current sources that can deliver this electrical signal to the nerves, and these electrical signals will take the form of biphasic pulses that will send to the electrodes. And then, if we do our job well, so if we apply the currents to the good place and in the good way, then we can expect that the device, the central pathways will transmit this information to the central structures, and it will be interpreted by this central nervous system as motion centers. And this principle was first demonstrated in animals by Cohen and Suzuki a long time ago, in the 1960s. So they applied electrical currents with implanted electrodes to different animal models, and they demonstrated that this electrical stimulation could kind of replicate vestibular information because they could evoke eye, head, and postural movements in the plane of the stimulated canal in different animal models. So this is what you would expect from head motion, and you apply electrical currents, and you get a similar response. So the first demonstration. But for years, these kind of demonstrations were mostly used for our fundamental knowledge, to gather knowledge about the vestibular. Until the early 2000s, where Dan Murphy and Winston Wong developed the first prototype, or proposed the first prototype of a vestibular implant to be used first, of course, in animal models. So they proposed a whole circuit. We will not discuss it, whether it's good or not. The long way, we've come a long way from here, but just the idea that this device took a long time to come. And probably this idea took a long time to come because we waited until the success of the cochlear implant to develop a similar strategy for this. But the idea was already born in the early 2000s. So that's more or less where our team started working on the idea, also around the years 2000. So today I'm essentially going to talk about the research that the Geneva Master team is doing, but know that there are other teams in the world working on similar concepts. For example, the Vestibular Neuroengineering Lab in Johns Hopkins, the Bionic Vest Consortium, which is working on a concept that's slightly different because they stimulate the ossicles only with continuous stimulation. And the group at the University of Washington, from whom we've heard a lot in the beginning of the developments, but today we don't have a lot of information. We know that something's going on there, but they're not very active in the field right now. But if you're interested in this research, you can go have a look at what the others have been doing. So as I told you, our team started work in 2004, and this work started by trying to reproduce Cohen and Suzuki's experiments in humans. In humans during acute trials in the surgery room, where we applied electrical currents to expose our nerves. We inserted electrodes close to the vestibular nerves and tried to see whether electrical currents could elicit the response that we wanted, the vestibular ocular reflex from the semicircular canal. So here you can see a video where you can see that it actually worked. We managed to elicit eye movements in the plane of the stimulated canal. We tried with the posterior canal, we tried with the lateral canal, and we were very successful. And that motivated us to start discussing our work with Medel, so that they could develop the first prototype of the vestibular implant being used in humans in 2007. And this is this first prototype in 2007. You can see here that it's a vestibulocochlear implant. It's a device that combines both a cochlear and a vestibular implant. And this prototype, the first prototype, had only one vestibular electrode to be implanted in the proximity of the posterior ampullary nerve, and the array, the cochlear array that was inserted in the cochlea. So you can see here that our device is designed for people that suffer profound bilateral vestibulopathy and also from severe to profound neurosensory deafness inferior to the implant. So this device is meant for both cases. This is not because all people with bilateral vestibulopathy suffer from hearing. You know that bilateral vestibulopathy can present even with normal hearing. But what we try to do here is to minimize the risks of the surgery by having patients that had already hearing loss, because implanting such a device could pose some risks of hearing. So this is why we started with this population, and this population exists. Because of the close proximity of these two sensory systems, you might have patients that have both impairments. So this is a population that is in need, especially because they have double sensory deficit. So don't forget about that. But not all patients with bilateral vestibulopathy have hearing loss. We kept on working with Medell, and they developed a second device in 2012 that had two electrodes, one for the posterior and one for the lateral ampullary nerve. And then in 2013, we had the first prototype with three electrodes, one per semicircular canal. We kept on working with Medell, and in 2021, they developed a new prototype that is similar to the one that I showed you before, but it's nicer, it's more anatomically correct with regards to the semicircular canal. Our surgeons love it. I'm not a surgeon, so I'm not that interested in the specific details, but I can tell you that it's easier to implant. It's more adapted surgery, and everyone seems to be pretty happy. But technically, it's not that different. It's just more suitable for surgery and for better positioning of the electrode, which of course is other. Of course, the external components have also changed a lot. So here you can see our first vestibular implant, which was computer controlled with a research interface. The patient was connected directly to the research interface, and this allowed us to make the first demonstrations of feasibility of the vestibular implant. But of course, this is not practical at all for real world situations. So we developed the first mobile interface in 2014. Here you can see the first mobile simulation for the vestibular implant that we developed in Geneva. Here you see the first patient testing it. It allowed us to make some very important experiments in real life motion settings or real life laboratory hospital settings, but with real motion. But of course, this was not very nice to be worn all the time. And another thing is that here you can see that we used the cochlear implant speech processor, and at this time we were only stimulating or the vestibular system or the auditory system, but not both at the same time. So we kept on working, and this laid a good technical background so that Medell could develop the first audio motion processor that you can see here that we have been using since 2021. This is a research device that we use in the hospital, but integrates most of the features that we want for patients to have in further trials. So you can see here's the processor, the speech processor of the cochlear implant that's born around the ear, the antenna, and here you see the same patient that you saw before wearing this new AF. Okay. So this is the Geneva Maastricht vestibular implant today. You see the external processors, the motion processor and control unit, the speech processor with the microphone, the motion sensor that's incorporated in the antenna of the device that communicates with the internal components, including the stimulator, the antenna, and the electrodes in the cochlea, and the three electrodes in the semicircular. And how do we fit such a device? In a very simple way. We try to replicate physiology, remember. So how does this physiology work? We have nerves, vestibular nerves, that have a resting discharge when the system is at rest. Okay, you don't move your head. These nerves discharge at a given rate in a more or less random way. Okay, around 90 spanks per second. When you move your head to one side, the hair cells towards the ear where you have moved your head, they bend their cilia towards the side of the biggest seal, which is the kinesiology. This causes a chain of events that depolarizes the cell and is replicated in the nerve as an increase of discharge rate. Okay, so the spikes become more frequent. When you move the head to the other side, the cilia move to the other side. This causes the cell to hyperpolarize, and the spike rate of the nerve decreases. So the spike rate of the nerve is modulated proportional to the acceleration and the direction of the head, because only the nerves that are in line in the plane of the stimulation get activated. So this is the way the system works. How do we do it with a vestibular implant? Well, we first apply electrical currents to the nerves so that we can restore this kind of resting discharge, because if we want bidirectional stimulation, then we need to first restore a baseline rate here that you can see here. And once we have done that, we can use signals or or motion sensors to modulate the resting discharge around this baseline level to generate bidirectional impressions of head motion, which, if you apply to the semicircular canal afferent, should result in eye movements, as you can see here. So here you can see a patient where we're applying these modulated signals to the posterior amplar nerve, and you can see this nice sinusoidal signal that follows the stimulation signal. Okay, now, is it useful? This is the nicest part, right? We've seen all the technical details. Now, can we make it work? So I think we have shown until now that the concept, the proof of concept is quite solid, that the idea should work. And what was our approach? Well, our approach was to consider the vestibular system as a whole. Here you see a very simplified pathway of the main vestibular pathways in humans. And what we did is we tried to probe each of these pathways independently to see whether we could activate them, and if we could activate it, whether we could control the stimulation. This was the approach. So we first started with the vestibular ocular reflex because it's the easiest one to measure and it's the most logical one in semicircular canals. And we demonstrated that we could, you saw it before, that we could activate and control the stimulation of the vestibular ocular reflex pathway, and we could also restore this reflex in clinically relevant tests, such as the video head impulse test. Here you see an example of a patient with a very bad VOR before this, and then we put the implant on, and you see that we can restore some gain in this vestibular ocular reflex, mostly in the excitatory direction, and that's also consistent with physiology because this would be the pattern that we would see in a subject with unilateral vestibular. We could also use this reflex to restore gaze stabilization abilities in these patients. We designed a dynamic visual acuity test where subjects were walking on a treadmill and they had to read letters while they walked. And we could measure the drop of visual acuity in patients with bilateral vestibulopathy. And then we could demonstrate that when you put the vestibular implant on, this visual acuity goes up again and goes up even in some cases up to normal levels. Not in all of them. In all of them it improved, but in some cases it even became normal. Okay, so this was very good news because this was the first ever demonstration of functional restoration of vestibular function in this patient population. Then we also probed the vestibular spinal rifts, for example, using VEMPs measurements, where we could show that we could evoke VEMPs that could vary in amplitude and in latency with the stimulation amplitude. We could also show that we were able to control the posture of these patients using modulations of the electrical stimulation. And we have also been exploring some higher pathways, for example, using electroencephalography methods and even more complex spatial navigation paradigms that are used in neuropsychological assessments. So if I summarize everything in one slide, and I'm only writing the main milestones, but we have done a lot of other things, you can see that it has been a long way since we started in 2004. And today, since 2021, we have a new processor that will allow us to do more real-life experiments with these patients towards the clinical application of the device. So I just like to mention that if you're interested in the field, it's worth to also read this paper here from the book from Charlie de Argentina that he published in the New England in more or less 2021, which also summarizes their work towards this device, and it's also very useful to see, compare what other groups have done. So this is a nice one to read. What do patients say when we do all this? It's also worth knowing what they think about it. They all liked it. They felt more stable with the implant. They said they really saw the difference. Most of them, all of them told us that they want to have it at home, of course, because we only do experiments in the hospital. One said he felt like he could run, although he didn't dare to do it. So that's also very good feedback. This one I liked a lot. I can finally concentrate on what is going on around me while I walk instead of concentrating on my legs. I think this really highlights the big impairments of bilateral vestibulopathy, where patients have to turn every automatic function into a conscious tiring effort. So this really is a very interesting feedback. And even the relatives, the close people of the patient tell us that they have seen the difference. He told us, for example, one man told us that he had never seen his wife walk so straight. So this is also a very interesting feedback. But now, we need to have objective data for all that if we want to achieve clinical application, right? So what are we working on? Of course, improvement of surgical outcomes. Electrode placement is very important. Of course, we want to have the best implant possible, minimize trauma, etc., etc. But because I'm not a surgeon, I'm not going to talk about this because this is not my field of work. What is my field of work? Technical developments, processor stimulation strategies, and that is working very hard with us on these different things. And these are important because our vestibular cochlear implant has very particular technical constraints. And why is that? First, of course, because it's a combined device that has to stimulate the auditory system and the vestibular system. And if you remember the stimulation strategy of cochlear implants, you remember that they use a strategy that's called CIS, continuous interleaved stimulation strategy, where each electrode is stimulated at a time at a very high rate. So you stimulate electrode 1, 2, 3, 4, 5, 6, and so on, and then start all over again, and that's very quickly. But if you want to stimulate like this with a vestibular cochlear implant, you have to know that you have to add the three vestibular electrodes, and the stimulation profile of these electrodes is not the same than in the auditory system. So you have to make the pulses longer than for the auditory system. And this is a challenge. So how should we do it without affecting the other function of the device? So you have to add these pulses, and you don't want to lose the efficacy of the auditory stimulation. So we did this study together, and we evaluated different strategies to introduce these vestibular stimulation pulses. And you can see that we compared different strategies, 1, 2, 3, 4, 5 to 6, where we added different profiles of vestibular stimulation gaps to the signal, either one, so we said, okay, each frame we only stimulate one electrode at a time, or we put the three of them within a single frame and see what's the effect on auditory performance. And these experiments we did with regular cochlear implant receivers, so to see what would be the impact of this on their auditory performance. And just to summarize it, here you can see the 7 subjects participated, and you see that overall, the performance was very similar, but that some strategies were slightly better than others. But I think that the good thing is there was no significant difference between simulation, which validates our strategy of simulation of these combined devices. Okay, what else? Well, we also need to validate performance during simultaneous cochlear vestibular stimulation, not only the stimulation strategy, but the performance overall. And this you can do different ways. Of course, one of the first things we need to demonstrate is that our patients will not lose auditory performance when we introduce the vestibular stimulation. That's very important. If they have a good benefit for their cochlear implant, you don't want this benefit to go down when you activate vestibular stimulation. So this, we first started with standard audiological measurements. For example, pure tone audiometry. Here you can see a comparison with 3 patients where we have done the audiogram, the pure tone audiogram, and you can see that the PTA values remain the same with or without vestibular stimulation. And we have also done speech audiometry, and you can see that the 3 conditions remain more or less the same in the same patient with or without vestibular stimulation. Now we're working on doing the other way around, so verifying that vestibular function is not impacted by auditory stimulation, but I don't have results to show you yet. Regarding the impressions of patients, we asked them how they felt with the different devices, so they have to compare the cochlear implant and the AMP, the audio motion process, and you can see that overall there is not a clear tendency. The performances, the subjective perceptions were the same, more or less the same in the group. 1 patient preferred the AMP, 1 patient preferred the CI, and 2 patients said it's okay. So we can say that there's equivalent auditory performance with the CI and the AMP, and that's very good news for the translation of the device also. What else? Well, I think this is the nerve of the battle. This is the most important thing that we have to address now. And you can ask whoever is working on the field of rehabilitation of patients with bilateral vestibulopathy, this is the most objective, this is the most scientific. The objective evaluation of clinical benefit. Because this population has a lot of problems that are often very difficult to evaluate. And the other thing is that the placebo effect is very big. And when you put a vestibular implant on, the patient knows it. What do you choose as placebo? what's the profile that will work as a sham activation of the device? And these are the main things that we're working on. We want to find some objective values, objective outcome parameters that are representative of patient symptoms, because clinical tests, you can do a video head input test, but it does not correlate with subjective symptoms of patients. So it doesn't work to show real benefit in everyday life. We need to find these parameters that are meaningful for patients, and we also need to find a way to compare these to placebo. So we're evaluating different things, for example, different gait parameters with our colleagues in Maastricht. We're evaluating different protocols. We're trying to find out which would be the best set of parameters in which conditions to have a short protocol that's meaningful and that can be used to assess the benefit of the device. So one of the first things we tried was slow, comfortable, and fast walking speeds in regular uniform background grounds. Now we're also evaluating uneven grounds and walking in darkness. And we're evaluating different parameters. The classical ones used in motion evaluations, such as spatiotemporal or kinematic parameters, but we're also trying to look at more parameters related to imbalance, such as the gait standard deviation, which will allow us to detect, for example, small changes in posture while walking, because these patients, they can walk maybe a while in a line, but at some point they will have some perturbation that can be detected with these measures, and also the head anchoring index that shows us what the strategy for stabilizing the head in the body is for these patients. These are the things that we're exploring. We're also exploring different tests to evaluate postural control, more static balance, using a new protocol developed, for example, for the APTest or other platforms. Here you can see one of the protocols that we used that was developed by Professor Robert Peterka in the United States, seemed to be quite sensitive to differentiate patients with normal vestibular function and patients with bilateral vestibulopathy, and also with unilateral vestibulopathy. And the third protocol that we're working on, that's I think will be very interesting, because it would be probably more easy to translate to a normal or current classical clinical setting, is the protocol of real-life tasks, where we have developed a battery of 15 tasks that are representative of the patient's symptoms. How did we build this task set? We used first the regular questionnaires, VHI, the questionnaires that we use to evaluate the patient's quality of life, and we had interviews with patients. So we had tried to design a battery of tasks, 15, that were of low, medium, and very high difficulty, so that we could evaluate them all along. And while they do these tasks, we put a number of different sensors. We have sensors, IMUs, motion sensors in the head and in the body. We have a cardio frequency belt, an eye tracking device that also records the environment, and pressure insoles that will allow us to measure the center of mass while they do this test. So we're trying to find out which would be the most selective ones and which would be the most easy to transpose to a very simplified clinical settings. And this we do for the moment in semi-standardized environments in the hospital. I'm just going to show you a couple of them so that you have an idea of what we're doing. This task is very classical of the symptomatology of these patients. They have to walk on an even ground, and here you see a healthy participant, and here you see a patient with bilateral vestibulopathy, and look at the difference. So what's the first parameter that comes out? It's an important one. Very simple. Speed. You just need a chronometer, and that's enough. And of course, we have also the base of support that's clearly different between both of them. And what's interesting of these two parameters is that you don't need any support. So these would be good candidates for clinical implementation quickly in clinical settings to follow up this patient. Another thing that we're exploring that can be interesting, but I cannot show you definite results yet, is gaze. Here you can see a normal healthy subject. What he has to do is walk in this hallway and look at the pictures that are in the window. And at the end of the task, he will have to describe it. So it's kind of a very complicated dual task. And you can see that he can do it very quickly. He walks and he looks at pictures and he keeps on walking. Look at the patient with bilateral vestibular. It's also slower, but it also takes him a lot of effort to go to the picture, stop, look at it, examine it, and then keep on walking. So this could also be interesting to evaluate. For example, in long follow-up trials, in longitudinal follow-up, they modify this strategy. We're evaluating it and seeing what would be the contribution. Okay, so all the work is ongoing. I hope I'll be able to show you some results in the coming years, but the idea of what we want to do is home, right? So one of the first things that we want to evaluate, of course, is find a good placebo and also know what we're measuring on each time. And I think that what you've seen from the organic stimulation is something that's also very important for us, because this stimulation is just a noise, but it's not modulating motion as the device that we're finding. And you've seen it before, just in the presentation before, that it can induce a very interesting benefit already, this constant stimulation without motion, which would be our baseline stimulation. So this is already some benefit. And the group in Las Palmas has also shown results that are very surprising, showing very good benefit from this constant stimulation. So what will we be adding with motion modulation stimulation? We need to find out to design good clinical trials. So the first thing that we're doing is we're trying to evaluate how patients perform with only constant stimulation with our semicircular canal electrode, so that we can then quantify what's the gain of motion modulation on top of it. I think it's a very important issue. So we're doing now this right now. We just finished the measures with 4 patients. We do gait sessions in the hospital. We do dynamic visual acuity tests in the hospital. And we also do some postural tests in the hospital, completed with quality of life questions. Then we send the patient home without any stimulation for 1 month and try to measure their activity at home using activity sensors, which is very important. We need to know how the movement pattern at home is for these patients, coupled also with questionnaires, because we need to know what they did during the day. And then we get them for the protocol. The first time we do measurements at the hospital, and I told you at home, the patients get all the measurements with the system off, and then they live and have the stimulation at home for 1 month. No, sorry. First we do it without stimulation, then they come after 1 month. We repeat the tests again, and we start the stimulation protocol. Then patients go home with the device. We measure their activity at home with the activity sensor and questionnaires only for 1 week, because it's a lot of work for them. Then they come back to the hospital to do some control measurements. So constant stimulation, come back, measurements at home, measurements at the hospital. Then they come back, we do measurements at the end of the protocol, month 4, and then we stop the stimulation and we do the measurements again. So we measure just before turning it off and just after turning it off, and then 1 month post the activation, so that we can have all this measure. I will not show you because there's a lot of data, but this is the summary of our results. We have 2 patients where we have a slight improvement in objective parameters after this activation, constant activation. 1 patient also reports benefits. 2 patients, no improvement at all. Caution, this patient wore the device very, very few minutes per day, so probably not representative and should be removed from the analysis. So what do we conclude? 2 out of 4 patients improved slightly, in highlighting the need of devices that employ motion modulation stimulation. This means that not all patients will benefit from constant stimulation. We clearly need motion modulation because some patients don't benefit from this constant stimulation anymore. And we also need to measure how much motion modulation adds. So it keeps, I think we're comforted in our choice of stimulation paradigm. And the other thing is that using baseline as placebo is not a good choice, because there is some benefit from this baseline. So if we want to design good clinical trials with placebo control, we don't use baseline. And this is a mistake that we have made in the past, because we tried to use baseline as placebo before, and we noticed right away that it was not as bad as off, so it's not a good choice. These observations have been confirmed by other groups, so now we have to find a good placebo. If anyone has a good idea for it, because patients know when they're activated or not, I'll be glad to hear about it. And with that, I'll close my presentation. Thank you very much.